Ladies and gentlemen, dear friends, thank you for joining this session sponsored by Jafron at the ERA meeting in Milan, Hemoabsorption in Chronic and Acute Clinical Settings. We're just finished the Vicenza International course on AKI and CRRT, and I must say that in almost every session, the concept of adsorption was discussed and debated, and the community of critical care nephrology also convened 3 days before the course in one of the ADKI consensus conferences. You might be familiar with ADKI because we generated the rifle, we generated the cardiorenal, we generated the renal dose, different concepts. And finally, we had a consensus conference on adsorption. So I think this is the hot topic of the moment. Everybody is invited to contribute to more information because we said that we are today with adsorption where we were 30 years ago with continuous renal replacement therapies. So hopefully it will not take us 30 years to come to the final conclusions that are not so final, by the way, that we have for continuous renal replacement therapy. Do we have quick questions for Professor Cantalupi, Professor Rimelet? Please.
Thank you very much for the comprehensive summary. My question is for Professor Rimelet. I know that this doesn't have a yes-no answer, but I really wonder in which patients shouldn't we insist on continuing the hemoabsorption therapy? I'm not talking about the very terminal patients. Like, of course, for the very terminal patients, we may decide to stop. But for the others, not the very ill, very terminals, but for the others, what should avoid us from insisting on the therapy? Yeah, I know we should start as early as possible, and I myself believe in the power of this therapies, and the evidence is clear. But I hope you got my question. Thank you.
So, Thomas, when do you stop and when do you continue?
So, of course, this is a very difficult question, and we don't have the right answer, but I can say a few things. First, there are different techniques. There are different cartridges and different sorbents, and you need to know the one you have in your unit, which is the target. Because, of course, if you have a cartridge, a sorbent that targets under the endotoxins, it's not the same as if you have a sorbent that targets cytokines, right? Then, when to stop? Yes, we need to stop as early as possible. And as you said, we are not going to start in all septic patients, right? You need to start, as you said, I think, in severe patients. You select correctly a population, and the ones they did, the strategy they used in Turkey, I think was good. They took patients with different organ dysfunctions, and then they see. To stop, Claudio, I think we need to see the answer, the feedback of the patient. How does the patient reply to this initiation of therapy? If you have an improvement, and usually what you look at, it's the vasopressor requirements, right? We look if the vasopressor requirements is decreasing. And if yes, I think we should go for another session. If there is no improvement after one session, I don't think, then in this situation, we don't apply another one, okay?
For the general experience we mature on the field, we normally prescribe in the people with impending cytokine storm and cytokine release syndrome approximately 1 or 2 sessions in the same 24 hours at the beginning in order to really prevent organ damage, etc. And then we follow up in the next day and the other day with another session every 24 hours in case there is a response. But according to our experience, after 2 sessions or 3 sessions, you see immediately a reduction in the amount of noradrenaline that you require to maintain hemodynamic stability. So again, you cannot expect then hemoabsorption to cure the patient or every patient forever and for every cause. If a patient has peritonitis, you need to send to the surgeon to real laparotomy and so on. But the important aspect, in my view, is the early application, try to identify the early responders, insist in case you have a blunted response, or you may stop in case you have a very excellent and good response. We have time for one more question, which I have for Professor Cantalupi. Vincenzo, you mentioned that protein-bound toxin can be dangerous, and I think that offering this type of therapy, we are offering something that so far we never explored, right? So can we expect maybe the use not only in patients for rescue therapy of symptoms, but in the future to prevent those symptoms?
Yeah, I mean, it's probably, this is the case. This is something that we have to explore because we don't have results. The results on classical diffusion and convection and the limitation to diffusion and convection are always more related to the unbound free fraction of protein biuremic toxin. So I think, yes, we are running together a kinetic studies, and this is also in my way the first thing to do to understand the removal of these harmful mediators. And then I suggested two potential applications that are obviously the most important alteration in our patient, in chronic dialysis patients, such as cardiovascular and neurological alteration that is highly underestimated. We have different sessions in this Congress about cognitive decline and neurological alteration, not only related to the vascular compartment. And so I think that after the kinetic, we should plan some more studies focused on clinical efficacy and long-term evaluation.
Yeah. So in the consensus conference of ADCI, we will come up with a manuscript where we stated that because it is going to be difficult to do prospective randomized trials, probably data collection and registries will be very useful. And we will provide a suggestion on a minimum set of data to record and collect when you do treatments for hemoabsorption. In this case, I want to stress the point that everybody of you can contribute to this information. So in the future, we will collect data, but possibly we need the same set of data in order to be able to establish some time of rules, indications, and characterization of patients. Everybody of you can really contribute to a small piece of information that we may need to expand our knowledge in this field. With this, I thank the speaker, my co-chair. I thank Jafron for organizing this thing and to provide the substrate for so much research. Thank you very much.